Tēnā koutou katoa. Thank you so much for that lovely warm introduction, Jacinta. Actually, today is the first day I've managed to get 2 shoes on, so I'm quite pleased about that, but I am hobbling a little bit. So if you want to stand on my foot, can you make it my left one? That would be awesome. Look, also thank you so much to Health Coalition Aotearoa, both for inviting me here to speak again. It's always a fantastic audience. It does feel like coming home for me, but also for all the work you do and being such a strong voice for prevention, for the things that we consider so important. Look, I appreciate the invitation to speak. I'm being followed by my colleague Andrew Old, who he's going to really speak in more depth about the public health infrastructure that we have now, post-reforms or peri-reforms, depending on how we think about that. So I thought I might sort of just take a step back. I'm only going to be speaking for 8 or 9 minutes about the broader environment in which we're operating. And I'm really looking forward to the conversation that we have at the end, a bit of, I'm really looking forward to questions and discussion, including the point about what could you do to help. As Jacinta said, I am currently the Director General of Health and the Chief Executive of the Ministry of Health. Previously, I am still a public health physician. And up until 5 years ago, I was Professor of Public Health based here at University of Otago, Wellington, along with Michael and a number of other people here. My research really from the early 2000s, which alarmingly is well over 20 years ago now, was particularly focused on cancer, but particularly inequities in incidence, survival, outcomes. So I guess the first point I might just say that personally and professionally, I'm committed both to prevention and to equity. As Jacinta said, immediately before the role I'm in now, I was the establishment chief executive of Te Aho Te the Cancer Control Agency. It was a huge privilege and a real highlight for me, being able to set up a new agency with this focus on cancer and the impact that it has on the lives of New Zealanders. But prevention was one of the really key cornerstones for the agency and remains so. We published a report on prevention policy options. I think it was 21 or 22, 2021, 22, not that number of options. But anyway, I thought it was an excellent report, but then I'm biased. But what we were really clear about, so that report looked at things like tobacco, alcohol, healthy nutrition, physical activity, chronic infections, those sorts of things, because we were very, very clear that no country can afford to treat its way out of the cancer crisis, for want of a better term. And of course, the same thing can be said about health in general. As Director General of Health, my role is to provide health system leadership and deliver on the priorities of the government of the day. So I think my role is best described in terms of what the role of the Ministry of Health is, and that may or may not be completely obvious to you at all times. The role of the ministry is to provide stewardship to the health system. But the trouble with the word stewardship is it's a slippery one. If I asked 10 people what stewardship meant to them, I'd probably get 10 different answers, probably a few shrugs. So I thought it would be helpful to talk you through the 5 core functions of stewardship. And these core functions are the 5 priority areas that the ministry arranges all its work around and how they relate to prevention. So the first one is this broad one, which is about coherent system level leadership, which includes for us a focus on ensuring equity is a priority for the health system. The second one is being the chief advisor on health to government. So that's not just to the ministers of health and the associate ministers, it's to government more broadly, and there's a range of things we do in that space, of course. The third one is about monitoring and driving system performance, which includes a focus on prevention. So one example there would be monitoring trends in smoking rates over time. The fourth one is being a regulator to the health system. So that actually includes a broad range of functions, from MedSafe, which does a medicine regulation. We've got abortion and end-of-life regulation, but we've also got regulation which relates to prevention. So tobacco and vaping regulation, fluoridation, those sorts of things. And the fifth kind of bucket of activity relates to working to future-proof the health system. And obviously, prevention and maintaining good health is really important when we're thinking about the future of the health system in general. And also there is some more specific prevention work that sits in that space as well. For example, planning for future pandemics, Michael. So, look, in my job, I spend a lot of time walking up and down Molesworth Street to talk to ministers and the Prime Minister, ministers both within and outside of the health portfolio, about opportunities and risks for the health system and for health in general, and also about the levers that they have to positively impact the health of New Zealanders. Once ministers have made their decisions, it's part of my role and the role of the ministry to ensure that they're set into motion to drive the health system towards the government's broad vision of improving health outcomes, with a focus on the population groups who have the greatest health needs. So you could argue that preventing poor health, or perhaps it's more sort of positive partners, enhancing well-being or supporting good health, is one of the fundamental functions of good government. I would make that case. The best options, as I don't think I would have to convince this audience, the best options to improve health sit outside of the health system. You know, we're thinking healthy housing, good education, participation in the workforce, healthy living environments, those sorts of things. For this reason, one of the key roles of the Ministry of Health is to work with other government agencies to ensure that health is considered broadly in policy. So there's many examples of that, but I thought one example I would just mention from my position is that I'm part of a social sector CE group, which meets regularly to consider ways to support people, whānau and communities who tend to be underserved and have poorer outcomes across multiple axes. So just to give you a sense, the other chief executives include the Secretaries for Education and Justice, the chief executives of MSD, Housing, Oranga Tamariki, and the Commissioner of Police. So we work collectively on a range of issues, things like family violence, mental well-being, the first 2,000 days. All of these issues are complex, they're challenging, they're difficult to shift the dial on. But what I can say is that there is a real desire and drive to engage with these issues and find innovative and multi-sectoral ways to improve outcomes for those groups. Within health more specifically, the Minister's indicated a strong focus on prevention in his government policy statement, the GPS, and that provides the health system with guidance as to the government priorities. So if you read the GPS, you'll find that the Minister particularly highlights the need to prevent and reduce the impact of 5 particular non-communicable diseases. So those are, if you haven't heard about them, you may have heard about them earlier today already, but cancer, diabetes, respiratory disease, cardiovascular disease, and mental poor health. And the government asks the system to focus on 5 modifiable risk factors: alcohol, tobacco, nutrition, physical activity, and adverse social and environmental factors. I don't think there would be much debate about the importance of those 5 NCDs. They account for about 80% of the mortality in New Zealand, and a common thread across all of them is that marked inequities are a key feature. So Andrew is going to be talking about how the system is responding to those priorities and what it's doing to address them. But I think it is heartening for us to see a clear commitment to prevention and early intervention across the modifiable risk factors by the government right up front. That is a good thing. We also see some focus on prevention in the health and mental health targets, which is another way of communicating government priority. So in the health targets, for example, we've got improved immunisation for children. Now, this is clearly hugely important. We know that Māori and Pacific children have lower immunisation rates than other children, and addressing this is an absolute priority currently across the system. From the mental health targets, the government has set a goal of 25% of the mental health ring fence, which is about $2.5 billion, is to be allocated to prevention and early intervention. I also think it's timely to briefly mention the government's focus on need and value. So all agencies, as you'll be aware, have been directed to ensure we are prioritising public services on the basis of need and public value rather than ethnicity. So when considering targeting specific population groups, agencies must provide a strong analytic case for any targeting, recognising that many variables can be used to identify and assess need, and that all variables should be considered rather than using ethnicity as a proxy for need. So as a ministry, this means we have to interrogate data to show where disadvantage and need is. We need to be able to demonstrate that we've done that. We need to demonstrate where and why our priorities are where they are. And while the government is clear that we do not use ethnicity as a proxy for need, we are very clear that it does not mean we cannot strive for better outcomes for priority populations. The government's also made a commitment to continue to address high Māori health need in a number of ways. So there are a few examples there. We're currently developing a specific Hauora Māori strategy with a sharpened focus on reducing the current gap in life expectancy and priority conditions. And the ministry is running wānanga across the motu right now on that particular document. There's a focus on strengthening local Māori health leadership on an ongoing basis through the iwi Māori partnership boards to drive community needs analysis and planning for Hauora Māori at the local level. And there's also strengthening the national advisory and monitoring role of the Hauora Māori Advisory Committee, which is an advisory committee directly to the Minister. So fairness, appropriateness and equity continue to be priorities in the delivery of services, albeit that we are required to frame those somewhat differently. So I really look forward to hearing from Andrew and Owen about the more specific work across the system, and I'm really looking forward to the conversation at the end. Happy to answer your questions either now or then. Thank you very much.
Thanks, Jacinta, and yes, it's always difficult when you get put on the spot what sort of fun fact comes to your mind and you instantly regret it. Look, tēnā koutou, ngā mihi nui ki a koutou katoa. I whānau mai au ki Kirikiriroa, I tupu ake au ki te papaioia, kei tamaki makaurau ahau e noho ana, ko Pākehā ahau, no Ingarangi, me kotirana oku tupuna, ko Andrew Old toku ingoa, tēnā koutou katoa. Look, it's a real pleasure to be here today. I was last here 2 years ago, and it's remarkable how much has changed and also how much hasn't in the last 2 years. Thanks very much to Health Coalition Aotearoa for the invitation, and just really want to thank and acknowledge my fellow panel members for this session, particularly acknowledge my boss, very important to do, but also particularly Tautoko, her comments, particularly about the leadership role that Health Coalition Aotearoa plays in the sector. Quick show of hands, how many people here were also at the Public Health Association conference in April? Only a few. Okay, that's probably, so with some apologies with what's to follow, but Ronald Reagan famously said the 9 most terrifying words in the English language were, "I'm from the government and I'm here to help." What he was getting at least in part, was that individuals or communities, given the resources, are usually much more effective than government that thinks it knows best. And I think on that particular point, possibly not much else that Ronald Reagan had to say, but on that particular point, I think he was absolutely right. So Di and I are from the government. We like to think we're here to help, but that's certainly not about what's us knowing what's best. So today I want to focus on the moment we find ourselves in for public health and the opportunities that we can grasp together. Public health is a long game. I don't need to tell any of you that. And we need to focus on improvements at a population level over generations, while also recognising and seizing opportunities as they present themselves in the short term. And I think you've heard today about the notion of radical incrementalism and sort of taking those opportunities as they present. To close our equity gaps and improve the health of all New Zealanders, we need to do both of those things. Over the past few years, the health system has been through enormous structural transformation, and there is more to come. We've emerged from a global pandemic that changed how we think about public health, both within the sector and across society. We've had a change of government who have new priorities and preferences for how public health challenges are tackled, and Di's touched on some of that. And we're working in a very different and changeable environment. But for all of that, many of the biggest public health challenges are, of course, the same challenges that we've been spending our collective professional lives trying to address. While there are some emerging challenges, so things like the impact of digital environments, the increasing urgency around climate change, and of course novel pathogens, which has been very much in the forefront the last few years, most of the drivers behind inequities, ill health and mortality in New Zealand are long-standing adversaries. So as Di mentioned, the public health system has changed. So those 2022 reforms, which seem like a very long time ago now in some respects and only yesterday in others, created a single national health system and from my perspective within the Public Health Agency, a single national public health service, bringing together 12 regional public health units along with other entities that used to sit along independently, such as Te Hiringa Hauora, functions that were previously part of the Ministry of Health, so the National Immunisation Program, National Screening Program. Within the ministry we have Te Pauhau Waratu Matanui, the Public Health Agency, and like the wider ministry, the agency is tasked with stewardship for the health system and advice to government, but specifically for us as it relates to public health. And as Di said, we also have a role within the ministry to coordinate and connect across government and broader society on the wider determinants. As up on the slide there, also want to particularly acknowledge the role of Hauora Māori services within Te Whatu Ora. They've become critically important to us since we don't have Te Aka Whai Ora providing that perspective now, and they're a critical partner on prevention and equity work, and remain important other relationships with long-standing partners such as Te Aho o Te Kahu and ESR. So the Pai Ora Act 2022 has given the health system a strong mandate for prevention and equity. It specifically requires the health system to achieve equity and health outcomes amongst New Zealand's population groups, strive to eliminate health disparities, in particular for Māori, and build towards a healthier future for all New Zealanders. Those expectations guide how we engage and collaborate and are very much at the forefront when we are providing our advice to government. So we do have a more unified public health system. We have a stronger, dedicated national public health voice than we've ever had before, and a clear legislative mandate for prevention. Di's mentioned the GPS, so what I've just popped up on the slide there are the prevention aspects of the GPS. So this was published back in June and is the roadmap for the government's objectives and expectations for the health system over the next 3 years. There is a clear signal around a shift to prevention and early intervention, and throughout the document you'll find prevention mentioned 45 times. It's not just about the words, of course, it is about what they mean. Some of the specific commitments to strengthen prevention in the health system are on the slide, but I think some really important intergenerational things like a focus on children, including immunisation, pandemic preparedness, a population needs-based focus for groups with the highest health needs, etc. That prevention policy is really being driven through a focus on NCDs, and so again this is a return to a theme that Di touched on. We know that NCDs, particularly the 5 that are up there, account for up to 80% of health loss and death in New Zealand, and we know that the burden of these diseases falls unevenly. It's been estimated that the cost of inequity between Māori and non-Māori is over $1 billion per year, for example, and Pacific peoples, people living in deprived areas, disabled people, women, rural communities, there's persistent inequities across all of those groups, and particularly also in the NCDs. We also know that children experience significant ethnic and socio-economic inequities in both upstream determinants and health outcomes. So we have been asked to focus on 5 modifiable risk factors: alcohol, tobacco, poor nutrition, physical inactivity, and adverse social and environmental factors from a public health and prevention perspective in order to drive improvements in these NCDs. So that's going to be a major focus for the Public Health Agency in coming years. The government's invited us to provide practical policy options backed by evidence that can make a difference. So that's really positive. Now, of course, listing diseases and listing fixes is overly simplistic. As you all know, there's a complex interplay between comorbidities, access to healthcare inequities, environmental, socioeconomic and other factors. But while it is simplistic, it is also a genuine opportunity for us to collectively create a public health policy program with the potential for real impact on health and health outcomes. Now, ideally, in order to do that, and I should add credit for this slide to our colleagues in the audience from the Public Health Agency, but ideally to do that we would need actions at every level, because we know that the biggest long-term population health improvements come from changes to environments. When you make healthy choices easier choices, physical activity easier, smoking harder, and when everyone has the social economic conditions to flourish. So to effect that change, action is needed across government and society. And we know that our biggest past public health successes have been when that cross-society, cross-government access effort is there. And again, this is not news to any of you, but I think what is new, possibly since the reforms, is that we do now have greater national coordination of some of these efforts. Di's mentioned a couple of examples of the cross-sector work that we do, but I'd just add some other things that we're involved in, such as working with the Ministry of Education on healthy active learning, ka oro ka ako, mana ake and mana kids, and working with the Ministry for Primary Industries on Trans-Tasman food policy, food safety, antimicrobial resistance and biosecurity. I've mentioned that the government wants to hear about interventions that can demonstrate a clear return on investment in terms of better health outcomes, both in the short and longer term. And there is and remains a strong interest in empowering local providers and local communities, and including iwi Māori partnership boards, to progress solutions within their own communities. So part of our job in the Public Health Agency is to draw together collective knowledge across the sector and from communities to help provide the best advice we can to government and ministers to help inform their decision making. And to do that, we need your help. We all have a role to play in weaving the cloak that was referred to in the first slide. And so what's up here is the policy cycle. This is just a fairly standard policy cycle, but what we've done is just tried to start to illustrate some of the ways that different players can participate in that. And there are many opportunities. So, you know, it starts with getting something on the agenda, and there's a really strong role for advocates in that space. Once government has decided that they want to do something about that, there's a policy process which is owned by the ministry, whichever ministry it is. And again, there is a strong opportunity for us to be partnering with sectors to make sure that we've got the best evidence-informed advice that we can get there, for example. There are opportunities through processes such as Select Committee, and just as an aside, in case you weren't aware, there is a smoke-free vaping bill in front of Health Select Committee at the moment, with submissions closing at midnight on Friday. So if you haven't already, have a look and get your thoughts into that process. So lots of opportunities to work together for better public health policy. So I do believe that there is a moment for public health. It might be a slightly different moment than it was 2 years ago, but it's definitely there. We've gone through a period of intense and often disruptive change. The pandemic, the health reforms, associated and ongoing organisational changes, and of course a change of government and direction. But through that, we've also built new capacities and relationships and have retained a clear mandate to address health inequities and improve the health of all New Zealanders. We understand the challenges, we know what needs to change, and we know that nothing less than our collective action across government, civil society and communities is needed to make that change real. Nāku te raudo, no te raudo, ka ora ai te iwi. Nō reira, tēnā koutou, tēnā tātou katoa.
Kia ora tātou. Tuana ki runga e tako maunga o Orowhana, ka titiri o whakararo ki te ao o Manukau o rereri nei. Ka tau ki te marae o whakamaharatanga, ko nā taki matu whāroa, taku waka, ko te raroa te iwi, ko Owen Sinclair ahau. Kia ora. Given from the bio there, you're probably going to expect that I might talk about immunisation and children's health, so no surprise there. But I'm going to talk about data. So there's lots of data out there. There's tons of data. This was presented in Parliament, I think it was last week. The Child Health and the Paediatric Society is involved in this. But the data, I think the data, the point I'm going to try and make is the data is being interpreted in the wrong way, and people are looking for the wrong things to address ethnicity, to address ethnic outcomes, and I've got grave concerns about the approach that's coming forward. You can see quite a rosy looking graph here on the festering sore in New Zealand, that is rheumatic fever. Unfortunately, that goes up to 2002. There was a break for COVID. Unfortunately, the numbers are now higher than they've ever been in 2024, so it's not looking very good. So we've talked about need. Need, as I hear it from this current thing, is universality. And universality is not good when it comes to addressing ethnic inequalities, because it doesn't really address the real things that are driving the inequity, which are harder to measure. They're in the data, and I'm going to demonstrate that now, but they're harder to measure and they're almost impossible to cost. And you have to look for it really hard. And so the first one, which I don't think the current regime wants to hear about, is systemic racism issues and racism. And so here we are. So there's a slide. So this is New Zealand's immunisation outcomes at 6 months of age, which is the lowest level we check the data for. You can see there's a couple of interesting things on the slide. That we are now recording the lowest levels of completion of immunisations at 6 months that we ever have. But also there's a couple of other very interesting things here that some of you may notice very quickly, that the single biggest predictor of whether a child's immunisation outcomes at 6 months is their ethnicity. And it's been tracked straight. It has never narrowed, and it's gone across over the whole time, like this sort of stuff. If you're going to try and address immunisation and you're not going to talk about ethnicity, I don't know what you're going to do. It baffles me. Rather unsurprisingly, we can see that Māori have much higher rates of immunisation preventable diseases and much higher rates of ending up in ICUs. Again, there's an ethnic thing there. I don't know how they're going to address it if they don't do that full on. So what are the other things in the system that does it? So actually, the immunisation system is relatively complex to do. So you have to be born, which is good. You then have to enrol. You have to enrol at a GP practice. To do that, you have to have a stable address, you have to have a phone, you have to have a car, and you have to have some money. If you don't have those things, it's really, really difficult. So rather unsurprisingly, if we look at Māori outcomes, Māori live in the lowest, this is adult data, in the lowest, 50% live in the lowest 3 deciles, so they have much lower immunisation rates. The enrolment thing is a real issue. So currently in Tamaki Makaurau, in the northern region where I live, 30% of pepe cannot enrol in GP practices to get immunised, including practices where their parents are enrolling. But it's worse than that. So even when they do enrol, we can see at 4 months of time, nearly 12% of Māori are unenrolled. And it's an automatic process. So we've created a complete systemically barrier racist thing, which is immunisation in New Zealand. So we have the most wealthy immigrants coming from Asia have the highest completed rates. They had no disease to start with anyway. And the population that has all the disease and who is the most poor in New Zealand has the lowest completed rates. This is systemic racism in a thing. That's how it works. These are the processes behind it. Now the next one that is very hard to measure and very hard to battle and difficult to cost to thing is bias. This sort of stuff. It is endemic in our system, and I'm going to give you a series of things why it's that way. So Māori children are born, they die at much higher rates than any other group. But also, even if they're born, so if they're born, this is with congenital left half obstruction, time is racing, you've got to have an operation, otherwise you die. The outcomes for Māori and European are significantly different, and if you look at those graphs, the reason they're significantly different, because Māori with exactly the same clinical outcomes have 7 times more chance of being deemed palliative. And the authors of the study could not explain why that was the case. Going back to immunisation, if we look at the graph again, I explained how that your immunisation uptake was directly related to your economic status. We can see the 2 lowest groups are Pacific and Māori. By some measures, Pacific are poorer than Māori, but you can see Māori are 20% lower. That's the effect of colonisation there, right in front of you. That won't be, this government won't pick that up. They won't see it. The other one that makes Maori so angry is this data has not changed for that length of time. So those two arrows. We know this. We know where these children are. We know where they can be. We just got to go and get them. It hasn't happened. And furthermore than that, Maori are blamed for this themselves. The discourse is Maori don't want to get immunised. There is no evidence for that. The Growing Up in New Zealand study asked hapu mama before they were born, do you want to immunise your children? 98% of Maori said yes. We can see this is the 2-year data, which looks much better. When we put efforts in, the gaps completely narrowed, and the rates of Māori and Pākehā ones came together, and also in COVID. Everyone says Māori didn't want to get immunised in COVID. 91% of Māori got a vaccine. 96% of Pākehā did as well. New Zealand loved the COVID vaccine, like that, despite what you're saying. Moving forward in the life course, children with asthma, Māori and Pacific are 5 and 6 times more likely to die of asthma, but when they go to primary care, they're less likely to get a preventer and they're less likely to get an asthma plan by quite some way. Trauma, Māori are much more likely to die of trauma in New Zealand, particularly in rangatahi. If a rangatahi goes to an ED department in New Zealand and they've had trauma, they are less likely to get a CT scan and other vital care. This means they have 56 times more chance of dying. This cannot be explained by any medical outcome at all. Getting older, sorry that stuff's been a bit stuffed up, but this is type 2 diabetes. Māori are 6 times more likely to die of type 2 diabetes, but if they turn up to primary care, they are less likely to get a BSL. Cannot explain it by medical outcomes, you cannot explain it by this, it's really hard to cost. And so what happens is, we have a life expectancy graph in Aotearoa that looks like this. So since the time of colonisation, there have been 2 people in New Zealand with respect to life expectancy, with Māori lower than Pākehā, and the gap has never ever narrowed. And this is the life expectancy here. What does it say? It's about 8 years younger, and it's always been that way, like this sort of thing. I could go on and on about this. These are all the things I could talk about, and this is just in child health, let alone adult health. We could go on forever. But it doesn't just occur in health. So the graph that I did it on Mac and it's gone, and we can see that incarceration, 50% of the prison population is Māori. They don't do that much more of the crime. You can see figures of diversion and custodial sentences are much higher in Māori. And also some of the inequities that occur in New Zealand have got their own special name. The one in education is called the long tail, and it refers to the distribution graph on the left there, where the long tail is the one that's very difficult to get, and that's never changed. And we can see that this is achieving NZCA there on the right, level 1, and overall all of the data has gotten better, which is great, but the gaps, the tail's still there, like this sort of thing. The gap, it's raised, it's like a train track, and it hasn't gone any better. So need, I've heard the word need today, I'm sorry, I'm not picking on you, it wasn't you didn't come up with it, like this sort of stuff. But there's also need, they talk about need and then they talk about it in policy. But anyway, so this is, I think it was yesterday's ESR graph on the incidence of influenza in Aotearoa. And the bar graphs on the right, on your right are the ones you can see that the incidence of influenza is much higher in Māori and Pacific. Children are a massive group, and also you can see that the sickest people are Māori and Pacific, and they get influenza at a much lower age. It was the same in COVID, so as chair of the National Immunisation Task Force, we begged Pharmac to fund vaccines for those 2 groups, and we were successful. But almost the first thing that Pharmac did this year, despite this obvious need, was to change it, and they took out the differential Māori and Pacific rate, and also stopped free immunisations for children. Not long after that, they made it much easier for people to smoke, and then funded end-of-life drugs that are incredibly expensive to treat lung cancer. They did this for cost. Doesn't make any sense to me. So I don't believe that need is being, I think it's going to be really difficult for the next while. People don't understand really what need is. They don't understand how to address inequity. They're not looking at the data in the right way, and if they're asking for costable outcomes of this, you can't cost or see. It's really hard to see systemic racism, and it's really hard to see bias. And those are the 2 major drivers of it. that I see out there. But it is an opportunity. So if we could eliminate ethnic inequalities or inequalities in general in our society, and I mean, it's not just there, it's like, imagine the economic boost if we could make pay parity between women and men. It would just massively increase our gross domestic product. It's the same in health. It's the same in justice. It's the same in education. If we could make the outcomes for the lowest groups, which are Māori specific, the same as the highest group, it would immediately improve everything. It's a task that's worthwhile doing. So what I would ask you to do after this sort of thing, that when a government is telling you you got to treat inequity, but you can't consider ethnicity because of need, I suggest you ignore them. Because it isn't going to work. And you need to target. You need to target. So kia ora tātou, nō reira, tēnā koutou, tēnā koutou, tēnā koutou.